to Chat Talks. We're delighted to be joined today by Albert Blankley from the Chief Operating Officer of Common Ground, and also delighted to welcome our Facebook Live viewers for the first time to this event. And for those that are new, anyone can ask us questions. Just put questions in the Q&A function, or for Facebook Live, just comment on Facebook. So here in Rochester, New York, we have actually one of the lowest rates of COVID-19 in the country. Out of a population of 750,000, we've only had 288 deaths. As of today, only 34 individuals in the entire county are hospitalized. And at the University of Rochester Medical Center, where I'm a neurologist, we have only 5 patients in the intensive care unit. The reasons are many, including that we benefited from the early statewide action in response to the outbreak in New York City. Another, though, is the outstanding work by many organizations at the local level. One of those organizations is Common Ground Health. Common Ground Health is a unique organization that brings together leaders from government, hospitals, insurers, universities, businesses, faith communities, and residents. And at the heart of these actions are data. They have more data on community health than any other organization in the region, and these data are used to improve our health. To learn more about what data they collect and how they use it, we are joined by Common Ground Health's Chief Operating Officer, Albert Blankley. There, Albert oversees research, information technology, and data analysis. Before joining Common Ground in 2013, Albert previously worked for the region's largest health insurer in policy and programming. He's also an adjunct professor at the Rochester Institute of Technology, where he teaches public policy, and previously completed a master's in science, technology, and policy, and an undergraduate degree in biology. Albert, welcome to Chat Talks.
Thank you. I'm thrilled to be here.
So the heart of most community health organizations is not data, but for Common Ground it is. Why?
Well, we really believe that data-informed decision-making is the best way to go about making change, particularly in our region. You know, it's interesting. One of the data points that I wanted to share, or a quote that I wanted to share, is from Don Berwick, who a couple of weeks ago published an op-ed piece that said, data needs to inform decision-making, or needs to inform action, but it cannot create action. And so our philosophy here is that we need to use the data to inform smart actions and to make change in our community and achieve the best outcomes that we can for everybody living here.
Where do you get your data from?
We get our data from a number of different sources. One in particular is the state of New York. So we look at utilization data from the State Department of Health. We also have a unique multi-payer claims database that has claims from the 2 largest health insurers in our community that we have updated on a biannual basis and are able to use in all of our planning and work with our community leaders. More and more, though, we have been working outside of the healthcare systems analyses. I think anybody who has worked with any type of administrative data is familiar with the problem that you get to a lot of the what with what you can see in that data, but you have a hard time getting to the why. And for us, getting to the why means 2 things. It means looking outside the healthcare system to other organizations. So we've worked with the city of Rochester to get housing inspection data and use that to help inform decision-making about housing development and planning. We've worked with our local transportation agency to get data on how people move about our region and crime data. And then the second thing is going to people themselves and trying to get a real understanding as to why we see different rates of different disease states, why we see different utilization rates, why we see different outcomes in different populations.
And so why do people share these data with you? They're often valuable, and do you pay for them?
Most of the time, we actually do not. We often enter into collaborative agreements with a lot of these partners. So we serve as a review organization for the state of New York's certificate of need process for hospital systems, which is how we get some of that data. We enter into collaborative work efforts. A lot of times the folks that have this data are organizations that really want to do things with it and understand it better. And what we're able to do is do that with a health lens to it. I would say the one group of folks that we actually do often pay for their data is when we go out to do focus groups or surveys. We really believe that it's important to value the time and effort that people are providing to that are giving us to give us the data. And so in those instances, we often find ways to provide stipends in one form or another for the people that are helping us understand what's going on.
All right, so you pay individuals for their time, but you beg, borrow, and share and collaborate data on crime, transportation, health claims, and housing inspections. You want to share us an example of how you're integrating these data across these multiple different sources?
Yeah, I'd be happy to. Let me see if I can pull up my screen here. So this is just one example from a recent survey we did where we captured 7,655 responses across 9 county regions, so a population of about 1.2 million. And you know, we were interested in this survey on a broad range of health topics, but really one of the things we wanted to understand is how people are viewing nutrition. And as we communicate with decision makers and leaders, both inside and outside of the healthcare system, one of the things that we often hear is that there's variations among communities as to whether or not there's appreciation for what eating healthy means and whether or not it's a priority for folks. And so we wanted to challenge that notion and see whether or not it held true for our community. And so just cutting by income here, what I think is really important to note is that almost the exact same percentage of people indicated that eating healthy was very important to them. So about 55, 56%. But as soon as you ask them to self-identify what their poor or fair, what their eating habits look like, you all of a sudden see a difference in what that return rate is. So of those who said that eating healthy was very important to them, of those making less than $25,000 a year, over a third of them said that they were not eating that great. Only 13% of those making $75,000 a year had the same response. And then when we dig a little bit deeper, and this was the power of the survey we did, to see what are the reasons that people aren't eating healthier, we find that, not a surprise, the cost is a barrier for folks making less money. But really, I think a notable item is the last one here. So transportation is a challenge. Almost a third of those folks that said that transportation was a challenge. We often talk about the social determinants of health, but these are really also social determinants of food security, social determinants of housing, all these other things as well. So this is just one example from one piece of work that we did recently.
Outstanding. I want to turn from nutrition to COVID. As we mentioned that Monroe County, where Rochester, New York is located, has among the lowest rates of COVID-19 of any place in the country. Why is the Rochester community doing so well with respect to COVID-19?
I think Megan mentioned one thing at the beginning, which is that we benefited from the state leadership and the situation that was going on in New York City that resulted in us making some pretty early decisions about what to do. But I think at a local level, what we have seen in Rochester for decades now is a spirit of collaboration. So for folks who don't know, we have 2 major health systems in our community that compete with each other on many different fronts. But when crises occur and when there's a need to collaborate, our community really comes together. And it's not just limited to the healthcare sector. We have been really focused on coming up with a combined message. So we've seen collaboration, making sure that all of our communications from our elected officials all the way through the various health organizations in the community has been similar, so we don't have confusion around communication. We adjusted quickly, and I will say that really the people of our community have stepped up in huge ways. This has not been easy, just like it hasn't been easy for anybody else. But when we look around, or when I go out and when I see, folks in the grocery store, at the gas station, wherever, you see really strong adherence to guidelines. So folks are doing a great job of staying as far apart from each other as they can. We have really high mask compliance, lots of folks doing disinfectant, and our local businesses have stepped up in the same way.
You're involved, and Common Ground's involved in numerous efforts around COVID-19. One is called Rock COVID. What is Rock COVID, and what can you show us about it?
Yeah, so Rock COVID has been one of these incredibly amazing collaborative efforts where we have partnered with the University of Rochester Medical Center, as well as with Rochester Regional Health, our other major health system, as well as the City of Rochester's government and the County of Monroe, the county in which we sit. Our county executive and public health commissioner, to come up with a symptom tracker that we've deployed across a 13 county region. And the idea of this, when we launched it, was to be able to add a new data point to all of the other data points that we're using to make decisions about whether or not to open, how to open, and ways to engage additional resources. And so the idea here is that we have recruited about 24,500 people on a daily basis to check in with us and just let us know whether or not they're having any symptoms of COVID-19. And the idea here is that if we see a particular area where we're starting to see higher symptom prevalence, that we may wind up deploying resources, educational resources, testing resources, in a culturally responsive way to those communities where we're seeing rises or potential rises in symptom prevalence. So it's one more data point to add to the litany of data points that we're all looking at. But we think that this is really powerful, as it can be potentially a more precise measure of where we're seeing symptoms. Now, that doesn't mean that necessarily there's an outbreak there, but it allows us to determine whether or not there is one, potentially more quickly than we might see if we were just relying on testing, case positivity rates, or utilization, so hospitalizations, ICU visits, that kind of thing.
You have this great map that you're going to pull up, and I see you've had over 20,000 people sign up to have their symptoms tracked, and you've had over 1 million screenings have been completed to date.
That's right, and that's what's really exciting. So we launched this in the middle of May, which was right at the tail edge of when we were seeing our highest utilization related to COVID-19, and since that time, we've screened almost 1.2 million. We've had 1.2 million unique screens of the data. If you go to rockcovid.org, this is the dashboard that you'll see. And it was really important to us to make sure that we were providing information back to the people that were helping us understand this. And this is one of the ways that we're doing that. So this is really just sort of an enrollment dashboard. So you can see sort of percent by population, participants by the counties engaged. There's a map of it. And then on the right-hand side, we talk about the symptom prevalence. And the good news, the really good news, is that we continue to see very, very minimal symptom prevalence, from about 2% those first couple of weeks in May down to about 1% now, and holding steady now for weeks and weeks and weeks.
But just to orient some people who aren't familiar with Monroe County, that's Lake Ontario north of Monroe County. If you keep going across Lake Ontario, you get to Toronto. If you go to your west, you hit Buffalo. You go to your east, you go to Syracuse. And if you go south, southeast quite a bit, you get to New York City. So 1%, is it even less than 1%? Are we talking at fractions of 1% of people reporting symptoms such as sore throat or cough or loss of smell?
It's really been hovering right about that 1% mark steadily. So, it jumps a little bit, 0.9, 1.1, somewhere in that range. But for the purposes of reporting out to the public, we decided to go with just one significant figure here. And that's what's really exciting. I also did want to give folks a little bit of a peek under the hood. So the technology here is not actually particularly complicated. The tool itself was built out of an initiative that actually started at the University of Rochester and has continued to be used, that is called Dr. Chatbot. And it's a really straightforward application, looks like a text messaging application that folks can go into, check in, and provide their information on a daily basis. We've taken that tool and deployed it across our region and made it public. So it's not just employees of the health systems, it's anybody that lives in our community is able to do this. But what's really important for us is making sure that we approach something that resembles a representative sample of our community. And to that end, we've created a number of internal dashboards, this being one of them, that tell us on a daily basis where we're doing well and where we need to improve. And the findings, my guess is, would probably not be surprising to most people. We tend to have underrepresentation of racial and ethnic minorities, underrepresentation of men, and underrepresentation of the youngest among us over the age of 18. But what that gives us the ability to do is really target our outreach efforts and our engagement efforts so that we're able to get more and more of those folks engaged. And that's where we've been really focused for the last month or so, as working on those numbers.
So on the flip side, you have overrepresentation of the older groups, which are at higher risk for complications for COVID. And it looks like you have nearly 200,000 assessments that have been completed for people over the age of 65.
Yeah, that's right. So, there's always bright spots, right? And we tend to focus on ways that we can improve. But I think one of the really powerful things is that, we tend to worry about older folks using technology. It does not seem to be a barrier in this case.
And then do you have any information on education of these participants, or is that not being collected?
No, it's not being collected. And we really tried to walk a fine line here. There are a lot of communities in our region that are worried about data privacy, that have a lot of concerns about some of the other methods that are out there. And so I know some of the other national trackers that are out there ask for a lot of demographic information. We opted just to ask folks for an age range, a zip code, a gender, and a race and ethnicity. And do not track individuals specifically. So it hurts us with regards to some of the specificity of the data, but where it does help us is in participation, because there are fewer ways that people can feel like they're being tracked.
One big issue with COVID-19 has been the disparities. African Americans are dying from COVID-19 at 2.5 times the rate of whites. The city of Rochester is 40% African American. How are African Americans in the city of Rochester faring?
Well, the answer is not particularly well. And we do have a couple of data points here that I'll just walk through really quickly. If you just look at the case rate, the positive case rate, we see rates amongst our African American and Hispanic communities that dwarf what we're seeing amongst the white population. We're talking 3 to 4 times as high. And that trend tracks through the other outcome measures. So if you look at the hospitalization rates, we actually see an even higher disparity there. And there's been a lot of discussion as to why this may be, both in our community and nationally. But I think for us at Common Ground, a lot of the inequities that we're seeing are really merely symptoms of what is a much larger systematic issue that we've been working on for decades, dealing with health inequities and issues like structural racism. And indeed, if you can call it that, the bright spot is that, the mortality rate, although still, over double what we see for the white population, is not as high a disparity as we see for the case rate or the hospitalization rate.
So can you go back a couple of slides? We'll just walk through for those who aren't quite as fast at reading this. So it looks like these in blue are white non-Hispanics, Black non-Hispanics, then Hispanics, and then others at the 4 categories.
That's right.
And so we see that 1,400 cases per 100,000 among African Americans, and which is quadruple what you're seeing among white non-Hispanic population in terms of number of cases of COVID. I presume this is diagnosed by testing.
That's right.
And
Positive test rates.
And then 5 times as high rates of hospitalizations in Monroe County, again, dominated by 2 major health systems. And then pretty close to the national average in terms of having 2.5 times the mortality rate. So although Rochester or Monroe County is doing well as a whole thus far with respect to COVID-19, the disparities that are being seen nationally are playing out just as much in the city of Rochester and Monroe County.
Absolutely. Sadly, that's true.
Any thoughts on how we can reduce these disparities, Albert?
You know, for us at Common Ground, as I said, this is something that we've been working on for a very long time. And, you know, the fact that this has come to light for a lot of folks is a positive thing for us. So we're recognizing that this is an issue. Really, when we talk about what to do to resolve this, there's some short-term things that we can do in terms of adjusting how we approach folks that are presenting with issues. But I think the larger lift and the more important lift is to think about all of the structural barriers that result in folks not seeking care earlier or being unable to seek care when they do get sick or from getting sick at all. Working on issues, the chronic disease issues that we know are risk factors for serious outcomes with COVID-19. So working on things like high blood pressure and diabetes and obesity are going to be really important. And those are all an artifact of decades of challenges that have been faced by both our racial and ethnic minority communities. But when you look at this by income level, we see that, you know, we've got rural populations in our region too that struggle just as much. So it's a bifurcated effort that we've got to take.
So I'm hoping we're going to get some more questions on this. This is unprecedented access to data at a community level, which is really hard to come by. And Common Ground has been a leader in this, but I'd be delighted to have you cross-examine Albert and push him more and seeing what other things we can find with respect to disparities. I know beyond COVID-19, Common Ground's engaged in many other community health efforts. Any other ones, maybe one that you want to show us is your favorite that you like?
You know, asking me to pick my favorite initiative is kind of like asking me to pick my favorite child. But one that I think is a really cool one to highlight is for 10 years now, we've been working on hypertension. And what I think is really powerful about the work that we've done there is that we did it both within the context of clinical care as well as in the context of community. So we created a high blood pressure registry along with our business community with participation from all of the practices, again, in a wide region. And then we use that data to build a community data set and reflect back to providers how they as a practice or they as an individual compared against the community control rates for hypertension. So providing sort of a competitive incentive for folks to do this. And this was before hypertension was a common HEDIS or core measure where we really recognized it was a problem for our community and engaged with our clinicians to work on basic things to address it. But we also engaged with our churches, our barbershops, our beauty salons in the city of Rochester to create a cultural awareness of hypertension, why it was important, why medication adherence was important, and what it meant. So that's what I think, you know, one of my favorite projects here has been that. And we have seen a lot of success. Our control rate has jumped up, I think 12%, and we're in the last 5 years or so, and we're up to close to 80% control across the community.
A huge kudos to you on the hypertension front, which affects about 25 to 30% of people who are hospitalized with COVID have hypertension, if not more. Last thing I'm going to ask you before I turn it over to our questions is around privacy. So When it comes to data, privacy is always a major concern. The leaders of the largest tech companies, Apple, Amazon, Google, and Microsoft got to spend the first part of this month testifying to Congress on their privacy practices. Why should individuals and organizations trust Common Ground Health with their data?
Well, we have decades of experience. So we've been collecting data in one form or another since our inception in 1978. And we have been protecting that data. We really have no agenda other than making sure that our community outcomes are the best that we can get. And just from a technical standpoint, we're not a qualified entity, so to speak, but we are a business associate, obviously, of a number of these organizations. And so with that, we go through HIPAA compliance audits. We do an annual penetration test. We hit our network as hard as we can all the time. We also have role-based access to all of our various data sets so that any breach would be limited to whatever that user has access to. And for anybody that's in the security field, and probably a lot of us know that your weakest link in your information security piece is your employees or the people that have access to the data. And so we do continuous ongoing training for every employee at the agency to keep it in people's minds and keep them aware.
So you have some sensitive data, housing and crime. Have you had any data breaches?
We have not had any breaches. And of course, it's impossible to say necessarily with 100% certainty that no one has ever breached our network. But what we do is we monitor and log all use of the data sets so that, and any suspicious activity is flagged, and most users don't have the ability to write to any of the databases. And to my knowledge, we've never had a breach that has compromised any of our data sets.
All right, I'm going to get some questions at first from those on Zoom. The great Dr. Sandy Mayer asks, the pandemic has highlighted the inequities in food security. Has your data brought any action by the community of food corporations located in our area to make food, for example, more accessible?
It absolutely has. We have a longstanding partnership with an organization called FoodLink, which is our major food pantry organization in our community. And at the outset of the pandemic, we worked with them very closely to break loose a bunch of regulations so that they could continue providing school meals without schools in session through the state of New York and through the FDA. And more recently, we have deployed, or they have deployed, I should say, in partnership with us and the local transit service, a mobile emergency food distribution, where it's essentially like an ice cream truck. It roams around various communities where we know there's significant need. We looked at the data, the food insecurity data, to drive that, and they go around in an RTS, a regional transit service bus. And anybody that needs food on that day can come out in the street, pick it up, no contact, and we're getting food to the folks that need it.
So rather than getting unhealthy ice cream, although I was soft spot for that, they get healthy food delivered to their community. The food is brought to them instead of asking people to go seek the food.
Exactly.
Jan Jernica was asking about raw COVID. For the 1% of individuals who are reporting symptoms consistent with COVID-19 infection rates, what proportion are testing positive for COVID?
It's an excellent question, and unfortunately, we don't know the answer. And that is one of the drawbacks of having taken the limited approach to the demographic and personal information that we took with this. So I know a lot of the other trackers that are out there from Carnegie or for MIT ask you to say whether or not you've tested positive. We've elected not to ask our participants whether or not they've been tested and if they've tested positive.
Is there any way in the future to link symptoms to actual results of COVID or to hospitalizations, for example?
Yeah, one of the things that we're looking at right now is that we have the testing data from the local health department. And so we're able to link at a zip code level to look at case positivity rates in a zip code versus what we're seeing in terms of symptom prevalence. And that's part of how we're testing the specificity and sensitivity of this as a tool for finding hotspots.
Joseph Vocal asked, are the age distributions of positive cases per 100,000 different among the 4 race ethnic groups? And might this account for the dissimilar mortality rates?
Yeah, so the numbers that I showed are not age sex adjusted. But we do know that those populations in our community tend to be older. And we also know that they tend to have more comorbidities that are associated with poorer outcomes. I haven't done the look to see whether or not that is specifically driving some of the issue, but it's certainly, I think it would be neglectful to say it's not a component.
Another question, appears that the disparity in hospitalizations reflects the disparity in infections, which seems to be the primary problem, not necessarily related to comorbidities. So access to healthcare does not seem to be the primary factor, more likely social or other work factors.
Yeah, I would tend to agree with that. That it doesn't seem to be, once people get access to care, we tend to see the disparities decrease. So as you looked at the mortality indicators, it certainly isn't where we would like to see it, but it's not as bad as what we see. And so, as I think about the reasons why we see higher case positivity rates, a lot of those populations are more likely to have been in that essential worker population, more likely to be exposed. And also there is a hesitancy to seek care among some of those populations, I think for really valid reasons. So by the time people do show up, sometimes they are further along than the other populations.
On the hypertension front, other than medical interventions, did your work affect lifestyle changes such as diet or reduced sodium intake, more exercise? And if so, how did you do it?
Yeah, absolutely. So with the clinical intervention was obviously focused on getting the practitioners to focus on this and make it part of their practice. But when we were working with the faith leaders, for instance, we developed a full curriculum around how to manage chronic disease, not just hypertension, but a lot of the same things obviously are important that have an impact on diabetes control as well as high blood pressure control, are good for obesity. And so we developed weeks and months long courses with folks, very similar to things like, if people are familiar with the diabetes prevention program, cohorting folks into teams so that we create a community around it, and also thinking about health as part of faith. As one example of ways that we approached, helping people to address lifestyle changes and working with what they've got.
Your organization isn't called Common Ground Disease, it's called Common Ground Health. Almost no one has talked about improving the health of our community so that people do become infected, they don't have much in the way of complications. 75% of people who are hospitalized with COVID either have hypertension, diabetes, or obesity. Why aren't we engaging in public health initiatives to have people exercise more, eat less, make better choices? It's amazing that no one's discussing this.
So for us, it is about structural changes that make those types of decisions easier to make. I think we have created systems that facilitate decisions that are not necessarily always in the long-term interest of our health. And I'll speak for myself because I think this is something that a lot of folks can relate to. I'm a father of 2 young kids. I have a demanding job. I've got a couple of side gigs. I'm busy and I'm tired a lot of the time. I don't always make the best decisions when it comes to my nutrition, right? Now, I am in a position of privilege where I have the ability to, work that off. I can go to the gym. Well, I used to be able to go to the gym, but I can still go for a run. I can create space in my schedule. I've got a lot of things in my favor to allow me to mitigate some of that. I can purchase healthier, more expensive food. But for a lot of people in our community, it is not a irrational choice when you need to feed your family and yourself. And the fastest, most efficient option to get calories so that people aren't hungry is to run through the drive-through. And when that happens time and again, what we see is the long-term impact. So what we're really focused on here is adjusting systems and frameworks so that those healthier choices are easier to make. And I would agree with you that I don't think we're talking enough about that, in the broader context.
So if you want to talk about that, let us know at, I think, info@chettalks.org. We'd love to hear from you. Before I wrap up with Albert, our next Chet Talk is next Tuesday, August 19th at noon Eastern, and we're speaking with Lee Shapiro, who's the CFO of Livongo. For those that don't know, the largest merger ever in digital health has just occurred earlier this month between Livongo, which is a disease management company focused on diabetes, and Teladoc, one of the earliest pioneers in telemedicine. And we have the CFO of Livongo speaking with us. Over the last year, their stock price has more than tripled. Want to know where the field of digital health is going, join us next week to speak to one of its movers and shakers. So Albert, next month, school returns, if not later this month. And New York State announced, I think late last week or maybe the week before, that the public schools were allowed to reopen. How will we be able to tell if a second wave of COVID-19 is emerging?
Yeah, it's a great question. I think we're going to have to look at all of the various indicators, including the symptom prevalence that we see. We're going to need to really pay close attention in the upcoming weeks to where we're at, and take swift action to make sure that any outbreaks that will inevitably occur are as contained as much as we can. Looking at the symptom prevalence, looking at the case positivity rates at the most minute level that we can, and deploying additional resources is going to be really critical to making sure that we can keep schools open, recognizing how important that is for kids and parents.
So most of COVID data reports deaths and cases. Are there any leading indicators instead of lagging indicators that can tell us maybe when the temperature is getting too high and we need to dial back?
Well, my biased response would be, let's keep an eye on symptoms, recognizing that we've got a lot of folks that do get infected that are asymptomatic, particularly among the youth population. But we can use the adults in those families as proxies and be paying attention to how things are spreading across our community via that symptom prevalence.
Well, Albert, thanks to you and to Wade Norwood, the Chief Executive Officer and great leader of Commonwealth Health, for all the work that you're doing to improve the health of the community and the health of people like me and families and friends and colleagues and peers. And thank you for joining us on Chet Talks. Next week, Lee Shapiro, the CFO of Livongo, a key partner in the largest digital health merger ever conducted in the United States or at any point in time, and an investor in digital health will be joining us. Until then, my name is Ray Dorsey, the Center for Health and Technology at the University of Rochester. Thanks you very much for joining us. Thanks again, Albert.
Thanks, everyone. Pleasure to be here.